decide to practice medicine and treat patients right here in Michigan. As our state works to attract and retain high-quality physicians to meet the growing health needs of seniors, children, and families, graduate medical education is an incredibly important tool that pays real dividends in real patients' lives. Our state is fortunate to have world-class medical schools, including the most recent addition of 3 new medical schools: Oakland University William Beaumont, Central Michigan University, and Western Michigan University. After our medical students graduate from medical school, they are matched with a residency slot. Residents are then typically assigned to teaching hospitals where they contribute to a healthier community at large by providing complex and acute care to underserved, indigent, and the elderly, including 28% of all Medicaid hospitalizations. The dilemma we are facing in Michigan, as well as the country, is since 1997, there has been a federal cap on residency slots. As a result, U.S. medical graduates, like those in Michigan, may exceed the number of available residence slots as soon as 2015. I believe you heard from a previous speaker regarding the inability of some to match nationally. It was very disturbing this year. The difference, though, is that Michigan has always been a leader in the nation of providing state funds for this critical investment for the future of medicine. That's why we are asking the Senate to restore the $1.4 billion cut from the governor's recent budget recommendation and to renew Michigan's long-standing commitment to health and safety of Michigan's patients. In his recent state of the address, Governor Snyder emphasized the importance of attracting bright new minds and exciting talent to Michigan. We believe graduate medical education makes that happen, but also it's an opportunity to make a real investment that produces both short and long-term results for patient health care. We want to be a better partner with the Snyder administration, the Senate, the House, to continue our state support for graduate medical education so that tomorrow's physicians can learn here, train here, and stay here. I brought with me today, beside me, is Christopher Wheat. Chris is who's going to provide you his perspective as a physician in training. Chris.
Thank you, Mr. Chairman and Senators. My name is Christopher Wheat. I'm a 4th-year medical student at the Wayne State University School of Medicine, also a lifelong resident of Southeast Michigan. I am pursuing residency training in internal medicine. It would be a privilege to train in Michigan, but that's not always possible. Let me please explain exactly the process that we go through pretty briefly as a 4th-year medical student looking to secure a spot in a residency. Last night, medical students, senior medical students across the country and I certified our final rank order list for the match. Those are our preferences of where we like to complete our training. For most of us, this is both the culmination of a lot of years of education, but also the start of a new beginning. For the most part, we've completed at least an undergraduate degree and are in our 4th year of medical school. But while we are earning our doctorate degrees in a few months, our training is nowhere near complete. To become a fully licensed physician in the United States, one must complete graduate medical education, or GME. That consists of anywhere from 3 to 7 or more years of residency training, potential fellowship training depending on specialty, where we work under the supervision of a fully licensed senior staff physician. To get to the point where I am today, senior medical students and I applied to scores of hospitals in the specialty of our choice, traveled across the country to interview with those who offered us interviews, and of the institutions of which we interviewed, we ranked them in order of our preference of where we would like to train, and the program directors ranked us, the interviewees, in order of the preference of who they would like to have trained there. Those preferences, or what we call the rank order list, goes into a central match algorithm, and on March 17th at noon, we'll find out if we match or not, and if so, on March 21st at noon, medical students across the country will simultaneously open up an envelope telling us where we will begin our training in a few months. That's how it's supposed to work. But that's not always the case. Last year, more than 40,000 applicants, including international medical graduates, participated in the match. Of the somewhat 17,000 that are United States medical students, 1,097 did not match, an increase from 815 the previous year. And even after the supplemental application process to fill the unfilled positions after the primary match, Last year, there were 528 United States allopathic medical students who graduated with an MD, but no path in place to practice medicine in the United States of America. The number of the unmatched is only going to increase, as you heard, as we have a stagnant growth of residency slots, but increasing medical school enrollment. Since 2005, 17 new medical schools opened in the United States, and since 2010, when I started medical school a mere few years ago, we've opened Oakland University, Central Michigan, with Western Michigan on the way. Now, having unmatched medical students is a shame for us soon to be physicians, of course, but it's a preventable tragedy for Michiganders' healthcare. It's pretty clear that those who will be most adversely affected are the most vulnerable populations, because 40% of all charity care is performed by teaching hospitals, which represent only 6% of all hospitals in total. But all of us are affected in some way or another, because the Association of American Medical Colleges projects that we will have a 90,000 physician shortage by 2020, and Michigan is proportionally worse off. Across all specialties, from primary care to subspecialists, Michiganders will increasingly have issues with access to provider care. I'm sure you all experienced for non-emergent office visits, sometimes you have to wait a little while to get in. Now, imagine that exacerbated by an increasingly aging demographic, along with a future inadequate physician supply. Now, that is why it is critical we have adequate graduate medical education in Michigan, because individuals who train are more likely to practice near where they train. We need to ensure that GME finds its safe haven here in Michigan, so Michigan students and medical students from other schools across the country can train here and perhaps practice medicine here in the future. I'm here to tell you today that graduate medical education is not just another line item on the budget. It won't get all the media coverage, not the trendiest political issue or make for a nice fire debate on cable news. But it is the foundation of our healthcare system, training tomorrow's Michigan doctors today. I urge you and your colleagues to support graduate medical education so that no Michigan medical student goes unmatched. Not only for my sake, I would be gone by then, but so that every Michigander, whether they're our neighbor, our family, our friends, our veterans, our seniors, those most vulnerable, will have access to a physician, because every Michigander deserves access to high-quality physician care. Thank you.
Thank you. Appreciate your testimony today. Senator Castlewater, your question.
I'm a little slow here. I understand you say that back in 1997, the number of slots in the hospitals for medical students was frozen. Is that correct?
That's correct.
Who did that?
That would be a federal mandate that was passed down in the budget, one of the budget acts.
And why did they do that?
Well, it's a
In your
very
opinion.
question to ask the federal government. And hospitals, some of them have incurred those costs and gone beyond their caps out of their own pockets, which has been certainly an issue with the hospitals, the tremendous financial burden that they've been experiencing over the years. And it's one that we fight every year going to Washington, D.C.
So it was an issue that by continuing to increase the number of students who come to the hospitals and do the residency, it was becoming cost prohibitive.
Well, students are coming in greater numbers because of the number of medical schools that are opening up. So we have a disproportionate number of slots.
The reason they capped it was because if they allowed it to keep going up, the costs to the hospitals were going to become prohibitive. Is that correct?
My guess is that I'm not going to sit here and tell the federal government what they did, but I believe what they did. We may have some other people in the audience much more eloquent than I, but I suspect it was one of those areas that they felt was not necessary to fund.
And so if we capped it back then, we're really not seeing the results of it until the last couple of years.
We're starting to see those results, yes, sir.
Okay, so we kicked the can down the road.
And it's going to get worse.
Okay, and we're doing this at the same time that I've been hearing, ever since I've been in Lansing, that we have a shortage of physicians in various areas.
That would be correct. Of course, some of that is specialty driven. Certainly, there's some concerns about family care, family practice types of specialties across the state.
So instead of getting from the federal level. And I'm asking this question, is it getting additional dollars to the hospitals to help fund and take care of the additional slots so that we don't have a doctor shortage? The decision was made to simply not allow anybody any more slots at all, which relieves financial pressure on the hospitals, but exacerbates the doctor shortage.
Well, I think your question may be better directed to the hospitals. I don't know what the decision-making would be at that level in terms of whether you're going to go over your cap and fund
So the federal government, in their wisdom, capped the number of folks going in because of the costs. So instead of them increasing the dollars to the hospitals to help pay for more slots, their choice was just to limit the slots.
that would be correct. The best of my knowledge, that would be correct.
Very interesting.
Thank you, Senator. Senator Gordon, do you have a comment?
Yeah, I just, to that, just so I understand it. Well, I only had so many slots. That's it. I've got only so many slots. That's just to help support those doctors. I could pay a doctor, somebody to come in because I wanted it, particularly whatever the skill was. I could pay them and have more doctors than the slots that are available. I mean, if I got that, I mean, these slots is just what I'm paying for from the federal government that you're talking about. Otherwise, I mean, I can take as many doctors as I want, I just have to pay them for a period of time, or whatever that time is. I don't know if I got to practice for 3 years or 2 years or whatever it is, but that won't, I can pay for it if I want that out. Have I got that right? Carrying out from where you are, Senator, on now?
Well, I think that you're talking about as a hospital.
Yeah.
If I was a hospital and I want to get more slots, I can pay for them. I can do that at the same time I'm seeing my rates for Medicare get cut, my rates for Medicaid get cut. I'm sure that's a very reasonable position to take. They're cutting the money coming out to us to put more slots in and pay for it myself. I think we're going to get some of those schizophrenic.
We are going to be